Welcome back to the podcast. I'm your host, Jeremy Miller. Every week, I chat with fascinating people from all walks of life in order to bring you knowledge, inspiration, and insight. If you enjoy the show, you can support it by subscribing, leaving a review, and sharing it with a friend. This is the Jeremy Miller Podcast. Dr. Kyle Gillett, welcome to the podcast, man. I'm super excited to chat with you today.
Thank you. My pleasure.
So before we dive into too much, do you want to kind of just give people a background on yourself, what areas of medicine you've studied, and what you're currently doing with your career right now?
Absolutely. I'm a medical doctor. I'm an MD, and I'm board certified in family medicine and obesity medicine. I consider my practice, I call it individualized medicine, which basically means taking the goal of the patient into account. And I'm most well known for management of hormones, obesity, performance in general, whether it's cognitive or athletic performance. I also like to try to keep myself healthy in the meantime. On my podcast, I kind of go through my health and fitness journey and struggles I've had along the way, having a couple kids. And as a lot of people know, I used to be a runner as well. And now I'm, I guess, CrossFit curious, for lack of a better term. But anyway, that is me.
That's amazing. I didn't realize you were a runner as well. How long you've been, well, you said you used to be more of a runner, now you're getting more into CrossFit, but how long did you run for?
Yeah, so I started running. I used to play a lot of basketball and soccer. Those were kind of my main sports, and now volleyball more is. But long story short, I was homeschooled, and I'd always planned to be a physician. My father was, practice full spectrum care, lifestyle first, as that is more powerful than any medication or supplement. But I knew that I wanted to deliver babies, do end-of-life care, everything in between. So after I was homeschooled, I applied to one college, and I thought that I was going to get a good scholarship because of test scores, and they didn't accept my homeschool transcript. So because I'd ran track and played basketball, I looked at some other colleges, and one D2 school happened to offer a track scholarship. So I did track. I guess my heart maybe wasn't necessarily into it, around the 800 and sometimes 400, but I ran plenty of miles, enough to know the struggles of running. And I've run some after that, but never anything like a 70-mile week again.
Okay, dude, that's awesome, man. I had no idea you were a runner in your past. Do you still run consistently now, or is it just kind of incorporated within more CrossFit style training?
From time to time, I do. Sometimes I'll go to the track with the family and run some laps. But yeah, it's more incorporated with my training in general.
Okay, nice. Do you do no long distance kind of stuff? No, go for a 5, 10, 15 mile run like that? It's usually just short kind of interval type stuff?
Sometimes I'll do a 5 to 8 mile run. And I think I could, God kind of gives everyone different gifts. I think I'm a decent middle distance runner, just genetically, the length of my femurs and my mitochondria, my PPAR delta receptors in general. But yeah, it's rare that I would go for a run longer than 5 miles, but I do like doing 5Ks. So I still enjoy reasonable running. It's very relative, because if you talk to someone who's not a runner, they'll say, well, you ran a 5K, you ran a really long distance. And then if I'm talking to you, then I assume you consider that a shorter distance.
Yeah, it's all relative, like you said. That's amazing. In your own training, have you seen any hormonal changes or pros, cons, any of that stuff surrounding running, or as you go through different styles of training?
Yeah, I wish I had started checking my hormones earlier. As I've talked about in my podcast, I have varicocele, which is varicose veins, and secondary to that, testicular atrophy, actually on both sides. But I never checked anything until I was in my 30s, till I had a couple kids. I knew I had varicose veins, and I thought that I would have fertility issues. So that's the main reason why I checked it. And I had a very good lifestyle after having my first son, because when I had my first son, I was probably 30 or 40 pounds overweight, excess body fat. So I used lifestyle interventions only to lose that. And then after I went through that process and had ideal health, I was like, you know what? I better get an ultrasound and just make sure that my testes are of normal size, because I probably want to have more kids than one. I have 2 boys now. And I was extremely upset when I found out that they were atrophied on both sides. I had never done any medications before that. I'm as natural as they come. And the older I get, the more I realize natural is better. and lifestyle intervention should be first. And then subsequently, secondary to that, I was like, yep, I should probably start HCG and do this and do that. And my journey has kind of gone from there, but I've definitely noticed it's a lot easier for me to put on lean body mass when I don't have a low free testosterone. And my SHBG also runs very high. Almost no matter what I do, my estradiol is just very low. I've done Dutch tests. I think that there's a relative aromatase deficiency, as things like osteoporosis do run in my family, and my DHT is very high and estradiol is very low, almost no matter what. So in my personal journey, I've definitely seen it. But yeah, like I said, I wish I had started testing things a lot earlier.
Interesting. Yeah, I it sounds kind of similar to me. I mean, my estradiol is crazy low. I don't, you don't have to share this if you want, if you don't want to, but like my FSH was incredibly low, and I think just based on my own Googling, that's pretty much directly correlated to your sperm count. Is that correct?
Yeah, it definitely can be both low and high FSH. So FSH is follicle stimulating hormone. Men don't have follicles because we don't have ovaries, but we do have Sertoli cells as well. And it's related to what's called the seminiferous tubules where sperm is made. So that also has crosstalk with Leydig cells where testosterone is made. And SHBG increases what's called androgen binding globulin in the testes. These names are stupid. It's the same thing as SHBG, which is the binding globulin that binds all androgens and all estrogens. And what that does in the testes is it helps bind up androgens like testosterone to increase intratesticular testosterone, which is related to sperm counts. That's why things like dutasteride that can decrease intratesticular androgen signaling can decrease sperm counts. So, yeah, long story short, a low FSH, especially if it is clinically deficient, which is usually under 1.7 or so, it can depend, can be correlated with low sperm counts, but also high FSHs can as well. I've never had an FSH over 12, but in general, if you have varicose veins or varicocele, if your FSH is over 12, and or if your testicular volume is under, I think, 20 cc's, then you have a higher chance of being subfertile or less fertile than normal and having low sperm counts or low sperm motility. So there's a couple things to keep in mind with that.
Interesting. Yeah, because I think mine was 0.8. So as far as I know, that's like quite low. Do you think that has anything to do with training or lifestyle, or is that more maybe a genetic thing?
Yeah, it has to do with both. There's also another hormone that can affect it. It's called inhibin. Usually inhibin B. There is inhibin A or inhibin B, but in men, inhibin B is the main thing that can cause suppression of FSH, but not suppression of LH. So, and that's a general rule that you can go by. So occasionally you test an inhibin. There are things called inhibin-producing tumors, but in you it is extraordinary, unlikely to be the cause of your low FSH. In general, low FSH is often secondary to low pulsatile secretion of GnRH, which can be for a lot of different reasons. Suboptimal sleep is a common cause of this, and then just being in a caloric deficit. So you're like a classic undernourished ultra runner, very common to see low FSH.
Interesting. That makes a lot of sense. Yeah, sleep. I could probably improve on some sleep, I'm sure. I think everybody can. But yeah, that makes sense for a caloric deficit for sure. And then the estradiol, is that common with endurance training? Lots of like overtraining, or is there any correlation between that and FSH at all?
Yes, there's very strong correlation, but the causation is likely mostly secondary to just having a low body fat percentage. The higher your SHBG, the less free testosterone you will have to aromatize, that just means if you have that high SHBG, again, that's the binding globulin that increases when you do cardio or consume low carbs. It's why a lot of people are getting away from that low carb recommendation for runners. Part of that is to bring down the SHBG. But that means you have a lower free testosterone. When you have a low free testosterone and a low body fat percentage, you're very likely to have a low estradiol. And as I mentioned in lots of podcasts, for males and for postmenopausal females, basically, if your estradiol is going to be below about 50 picograms per milliliter or 50 on a normal assay, the ECLIA, which is what you get at most of your doctor's office, is not very accurate. So if it says 10, it could be 5 and it could be 25. But a sensitive estradiol, that tends to be more accurate.
Interesting. Yeah, I tend to follow more of a low carb approach. It's harder with marathons. I definitely have to take in more carbs for marathon stuff, the faster stuff, but primarily low carb. So it sounds like there could be correlation there. In terms of both of those, like, are there things to combat both of, like, just for, in my case, like low FSH and estradiol? Are there like specific things that I should maybe implement to kind of combat those and get those back into normal ranges? Or I guess first question would be like, are there anything to worry about right now?
Nothing to worry about. Probably the next step that I would take is the step that I took years ago, although I didn't have a low FSH. If you have varicose veins, it's very unlikely that you have a low FSH. Even if you're an undernourished runner, it's possible. But it's more along the lines of, I don't know if people have heard of hypothalamic amenorrhea, or HA. That just means it's seen in female runners extremely commonly. But there is a male subtype of that, just like there's a male subtype of PCOS, there's a male subtype of this HA. And that is also known as hypothalamic hypogonadism. So anything that can help the release at the hypothalamus, this is a bit more complicated, but the way I explain it is like turning on a car or a UTV with multiple switches. You have switches that are pretty well known, like leptin. So leptin is a satiety hormone that's released from fat cells that also binds the hypothalamus to cause basically that hormonal cascade to start. So that's why, you go in, you have hypothalamic amenorrhea, or you're a runner with hypothalamic hypogonadism, and the doctor's like, well, eat fat and gain weight. And you're like, well, geez, thanks. That was really helpful. But the mechanism behind that, whether or not the provider might be aware or not, is that, yes, it can help with leptin release. Sometimes we even use exogenous leptin, although in your case, it would not be recommended. But the main takeaway for a lot of people that are very health conscious is that you don't want triglycerides to run too low. So high triglycerides can actually help leptin build up. And one of the main things that modulates that is omega-3s, specifically EPA. So if you're over supplementing with omegas or EPA, which many health conscious people are, then you can back off of that EPA, maybe supplement with just DHA if you need it. And that way your trigs run a little higher. You can consume a little bit more fat as part of your calories. And then that leptin can run a bit higher. So that's switch one. Switch two is kisspeptin. I'll go a little faster through that one. That's basically a hormone that's made in the limbic system, or the emotional system of your brain, that binds to kisspeptin-related neurons in the hypothalamus. So emotional, variability of any sort. So if you're stressed, that's kind of where one of the root causes can come in. And that's also likely why a lot of males who live around specifically ovulating females. So if you have a spouse or significant other, you live with her, she's ovulating, ovulation is not suppressed, FSH might be higher. It's a little controversial. It's hard to say causation or correlation, but I think a lot of that's due to kisspeptin. Some people also take kisspeptin, but it has a lot of side effects. And in general, it's not used except in fertility cases. And then estradiol also has a permissive switch. So some people take a touch of something like estriol to let estrogen have that permissive effect at the pituitary. And then it's like turning the three keys at the same time, and then it comes down. There's one more key, I'll mention it just for comprehensive sake. It's alpha melanocyte stimulating hormone. So that's when you get sun exposure. For runners, that's probably not the rate limiting step.
Interesting. My gosh, this stuff goes so deep that I've never considered a lot of these different things. But I mean, this is exactly why I wanted to get my blood tested. And this was actually the first time that I had ever gotten it tested. And this was basically peak marathon training. So I was doing 60 to 70 miles a week. I'd be really curious now just to get more of a baseline to do it again now that I'm not training for a marathon. Hard to tell exactly how long it takes to recover from everything, but I definitely do want to get it tested within the next month or two to hopefully get more of a baseline and kind of compare and contrast. As far as endurance training in general, are there like pretty common hormone things that people should be on the lookout for? Like is the estradiol pretty common for runners, or different, like low testosterone, from what I've heard, can be pretty common for endurance athletes? Are there like some kind of markers people can look out for?
Yeah, definitely. One of the things that you should definitely be on the lookout for is high SHBG. which is correlated with low free testosterone. So that's your sex hormone binding globulin, and I would include it in every test. Most assays for testosterone that also test free testosterone are not accurate. So you should calculate your free testosterone using a total and an SHBG. And you can just go online, you Google free testosterone calculator and find out what your actual free testosterone is, or your calculated free testosterone, which is generally more accurate. We already mentioned the sensitive estradiol assay, which I'm happy to help you order. Although if you're Roche ECLAA, which is the least accurate, not the least accurate immunoassay, but the least accurate orderable assay, if that's low, then it's probably likely that your sensitive estradiol is also low. But keep in mind that SHBG also binds estrogens. So your free estradiol is likely even lower. And there's a few things that you can look at for this. I like if people tested DHEA. In the past, I've taken DHEA, not because I'm very low in DHEA, but instead of using DHEA as a testosterone booster, of which there's no actual real testosterone booster, but there are testosterone vitamins, which a lot of runners should consider. Selenium, boron, magnesium, vitamin D, insulin. If you're missing one of these things, these are very easy to address via supplementation. Just like it's hard for a vegetarian to get a full complement of nutrients and vitamins via the diet. Supplements are a great way to just make that easier from a day-to-day basis. But yeah, those are some good things to look at. DHEA is a great estrogen booster, of which you likely could consider.
Interesting. It sounds like you'd probably recommend getting on, or at least trying supplements before getting on, like a testosterone routine, I would imagine.
Yeah, in general, the first thing is I'd like to identify the root cause, which arguably we have a really good idea in your case. And then secondary to that, you ask yourself, think of a Venn diagram. That's when you have different shades and it overlaps in the middle. What is the patient's goals in this case? What is every possible evidence-based outcome? Sometimes there's only one or two, but in the case of hormone optimization, there's dozens of paths that you could go down. And then take into account the shared decision-making component, or the place in life where the patient is. Are they going to be desiring fertility soon? Are they worried about epigenetic changes? And then what adverse effects downstream of whatever therapy we choose are there? So the more aggressive the therapy, in general, the more adverse effects or the more complicated it becomes. So for some patients, and yes, usually they're older in age, but not always. Age is kind of just a number. Often they want to escalate to more aggressive therapies because they're less likely to want to imminently desire fertility, regardless of if they have sperm cryobanked or not. And then they're often, think about it, they're more on a clock. So they don't have as much time to go trying to naturally optimize this or that. But in most cases for individuals your age, I always at least try to get to what is naturally possible first. Because if nothing else, if someone still just goes on TRT because that's how because the benefit outweighs the risk, then it still tells them what they should expect to get to if they ever choose to come off.
That makes sense. Yeah, it seems like everybody's on TRT now, and even like young people like myself, or I'm not on it, but young people, similar age as me, are on TRT, and I'm like, I feel like there's so many other things that can improve your testosterone. And are there any negative side effects of TRT? From what I know, I feel like I only hear people talk about the benefits of it.
Yeah, there's a whole host. Just did a podcast on that came out today. I have a chart here. I guess I could show. It's called the TRT iceberg. So you think about the Titanic. Most people can see what is above the surface of the iceberg, but an astute boat captain will see what is below the surface of the iceberg and be thinking about all the causes, because as the Titanic knows, you can hit the iceberg without hitting the top of it. Most of it is hidden, and TRT is that same way. The main ones that I would worry about is 1, risk of AFib, 2, risk of blood clots, even though it is a very small risk. It's important to know your genetic risk and stratify that. And then 3, any androgen, including testosterone, is and I've just started calling it this, a reverse statin. So statins will inactivate the same enzyme that any androgen activates. So that's a kind of like an insidious cause, because maybe you just have more plaque buildup in your brain. Maybe it's not in your heart, and maybe you just get early cognitive disease from that, and you're at risk of late onset Alzheimer's. So shortening your health span that way. Now that's there's a mechanistic link between there. There's not a whole lot of evidence-based links, and there's certainly a lot of benefits as well. But there are a lot of side effects to TRT, and most of them people never know they have. Ever. They just don't know.
Do the side effects increase as maybe like the age decreases of the patient doing it? Like say somebody who's 25 versus somebody who's 45, are the side effects the same across the board? Or does it change based on their age?
In general, at earlier age, there's less risk of VTE, which is blood clots, and less risk of arrhythmia like AFib, but there is more cumulative risk because people tend to push the doses or do TRT plus. And you can extrapolate a lot of data from bodybuilders who have done blast and cruise for a long time. And it's very hard to tell because you're like, well, am I concerned about plaque buildup in the heart? A lot of people are too young to have calcified plaque. It just has not had time. So it's all soft plaque that's invisible on a calcium score. And I jokingly call this the Sean Baker calcium score because he famously got one like 5 something years ago, and there's 0 calcified plaque, but he was too young. In 40-year-olds, I've seen greater than 70% blockages of an artery called LAD, which is one of the main ones, and a calcium score of 0. So there's a lot of I call it ApoB years. That's one of the terms. It's like pack years of smoking. It's not like, well, if you ask the same question about smoking, if someone smokes from the age of 20 to 25, 4 packs a day and then quits, are they going to be fine or have any side effects? I could see some people arguing they'll be completely fine and have no side effects. And then 15 or 20 years later, no negative outcomes whatsoever. They certainly have less negative outcomes to where if they continue to smoke a pack a day, for the rest of their life. But I wouldn't say it is completely side effect free. Often you just don't realize it. Maybe you just have a tiny bit more plaque in the small arteries in your brain.
Interesting. Going back to running, is there like a limit somebody should set? Say let's like hours per week, training in like zone 2 or a certain amount of miles. Obviously, it's harder to quantify that, I guess. So maybe sticking like hours per week. But is there like a recommended amount of endurance training? I'm sure it's incredibly subjective, but are there any like? So basically, like, is there a kind of a hard number where people just start getting into overtraining and starts having too many negative effects on their hormones?
Yeah, they're like a lot of things. There's obviously a wide spectrum or continuum for this, but in general, if you look at the zones of training, as you become more and more trained, it's easier to stay in a lower zone, for example, zone 2 or zone 3, for a longer period of time. And that's how a lot of elite athletes can relatively prevent overtraining. However, even within that continuum, if you're running, let's say you're running 90 miles a week, in general, if you are a higher body fat percentage, females tend to have higher body fat percentages, not always for runners though. That's why you see a lot of the female athlete triad in females that have been running for a long time. But in general, if you have a higher body fat, you have relatively more resistance to overtraining, and you're probably at the higher end of the spectrum in terms of volume. In general, if you're a heavier individual, I happen to be heavier, mostly because I'm very tall and lanky, then it also tends to be harder. I noticed that I got overtrained very easily and that I did not require a lot of high intensity or high mileage or high volume training to do well in my races, given they're mostly just 800s. But there's a pretty wide continuum. And someone like me, I tend to get overtrained pretty easily from running. And then let's say there's another individual who can maintain a decent body fat level. And I'm not talking about like 20%, but for a runner, a decent body fat level might be 12%. Because there's a lot of runners that just like to be shredded. And in that case, they're probably not going to have their optimal training volume outcome, if that makes sense.
Yeah. Do you know, is there like a range for body fat percentage and is that strictly for runners that they should kind of stick to, or just like humans in general?
Humans in general. There are some exceptions. Tristan Lee, for example, that just comes to mind. He's shredded all the time. But in general, I'd think 8 to 15% for males on a DEXA scan. Some things like the in-body, I've seen 20% on an in-body and then 30% on a DEXA scan. So DEXA scan, sometimes it's the same as something like an in-body, but sometimes it's 10% different, even within the same week or the same day. And then, yeah, for a female, probably between about 18% and 27%. And runners tend to, so there's a bit of what I call selection bias. So it's like selection bias or even hindsight bias. It's like, well, the elite runners that you see can train at a body fat percentage on the very low end of the spectrum. You know, a lot of females at 18% and a lot of males at 8%. And they don't get overtrained. And yes, when you do the bioimpedance, I remember I think it was 6% when I was in college, and there's no way I was 6%. So the ones that the athletes hold, that's not going to be equivalent to a DEXA. These are more DEXA percentages. Not that the DEXAs are perfect, but anyway, it's because all the other athletes that have tried to train at that percent body fat have become injured or overtrained, or they weren't able to make it.
Interesting. Yeah, I feel like, I mean, if you look at the top elite, like marathon runners, for example, they are skin and bones essentially. So I don't know what their body fat percentage would be, but it's got to be single digits, I would imagine. And I would also imagine that they're probably not maintaining that all year round, and they go in and out. I would hope, at least, because it sounds like there's a pretty direct correlation maybe between injuries and that body fat percentage, or at least overtraining and that body fat percentage.
Yeah, a very high percentage for the average individual. Like you mentioned, there's always going to be elite outliers, but yeah, skin and bones, I was 180 to 185. And that's when I was best at running, 5Ks, but certainly not my best weight for health or even running 400s and 800s.
Are there benefits or maybe pros and cons between doing like short distance sprints, like, 100 meter, 400 meter, 800 meter, as opposed to doing marathon training or ultra marathon training? In terms of hormone effect? For
hormone effects, no. There's a lot of studies that look at the, for lack of a better term, intra-exercise spike in IGF-1 and testosterone. And if you add those up for a long period of time, they have a cumulative localized benefit. Think of so endocrine hormones are hormones throughout the whole system. Autocrine is the same cell, and then paracrine is right next to it. There's a lot of autocrine and paracrine benefits of those hormones, but there's not the systemic benefit of those hormones. And that's the same for testosterone, IGF-1, IGF-2, et cetera.
Okay, so it sounds like sprints have maybe a little bit more benefits in terms of just testosterone, maybe? Is that an easier way to put that?
I'd say neither sprints nor distance running has and I'd say both interval training, because a lot of people are like, well, you have to do intervals. You can't do high intensity steady state. You have to do a high intensity interval. That's really when you get the hormone boost. That's not true. There is the autocrine or paracrine benefit. So like the localized benefit, for example, for your legs. If you sprint a lot, then you're going to have a lot of the hormonal benefits on the leg tissue itself, but you're not going to have the systemic benefits of actually improving think about the area under the curve over 24 hours. How much of that area under the curve is shaded in with testosterone, growth hormone, IGF-1, et cetera. Neither this high intensity or low intensity steady state, nor the high intensity or low intensity interval training will give you those benefits.
Interesting. So is there anything good that comes out of running? Because it doesn't sound like it does a whole lot or at least hormonally speaking.
Yeah, it's great for your health span. So think about I think Peter Attia uses the term centenarian decathlon, things that you want to do when you're 100. And both running and sprinting and jumping has significant benefits for this. Running and also sprinting is, of course, a form of axial loading with your body weight, unless you run with a ruck or a weight vest or whatnot, which is great. But that axial loading has a benefit after some period of time. Obviously, there's downsides, and I know a lot of people at some age, they switch from running to like medium intensity rucking or weight training or farmer's carries, things like that. But there's a lot of benefits. Use it or lose it is definitely true. So if you want to be walking in your 90s or past 100, then you likely do want to be running to some degree, just in a healthy way.
Okay. And is that more maybe correlated with like your overall heart health, you think?
The health of the cardiovascular system in general is good because you're going to form what's called a lot of auxiliary vessels if you need to. Some runners or triathletes, they'll have a small infarction or a small, technically, heart attack, and then they have such good blood flow that they'll form the arteries that are around it will enlarge and make up for that deficit. And that can happen throughout the body, not just the coronary arteries that supply the heart, but anywhere else, the arteries that supply the brain, that can also be a benefit. Running is, other than just the axial loading and the force that your joints take, especially if you're not running properly, it's not significantly different than, say, rowing or swimming for the cardiovascular benefits.
And what about maybe the mental benefits, mental health benefits that can come from things like running, like release of endorphins and some of these other, neuro hormones, I guess. I don't know if that's the right term for them, but but maybe some of those benefits also play into that.
Yeah, it's true. There's this theory. I love theories that make a lot of sense. For example, everybody has a pituitary adenoma, which we don't need to get into, but one of them is everybody has to be addicted to something. And maybe I just like the theory because personally I kind of find it true. You have to be addicted to some form of exercise. There's to be something that you're working to. I call it a movement pastime to last a lifetime. And it's once you get hooked on running, then you can certainly become addicted to it. So there's a lot of mental health benefit to that because it crowds other things out of your life. The caveat or the catch-22 to that is with runners and swimmers, even more so swimmers than runners. But those two sports tend to be most likely to overconsume alcohol, probably just because it's a food of high caloric density. But that'd be the one thing to watch out for if if running is your addiction per se.
Interesting. That makes sense. I mean, a lot of run clubs and everything that they meet at breweries or bars and consuming beer or something afterwards. That makes sense.
Yeah.
Interesting. Have you, just kind of a side question, have you seen, I think it's called The Blue Zones on Netflix? It just came out a couple weeks ago.
I haven't seen it. I'm familiar with the term, Iceland, Okinawa, Costa Rica. They're basically zones where people tend to have significantly longer health spans, healthy, long lives. And there's a lot of correlation, but things that you have in general, the pillars of health, diet and exercise are the first two. Some are vegan, some are mostly animal-based, but they tend to consume a lot of whole foods and not very many ultra-processed foods. They tend to also exercise a lot. Again, movement pastime to last a lifetime. They tend to have very good social connections and a strong sense of community. So although now that Netflix made the Blue Zone, everybody's going to invade them and then ruin their social health.
Yeah, the show is really good. I hope it doesn't have that effect on the people living there. But that was a perfect summary, and I think that's a good segue into your 6 pillars of health that I've heard you talk about. And you kind of just hit on some of those, but do you want to just say how you define those 6 pillars of health?
Yeah, diet. The optimal diet is one that you can adhere to for the rest of your life. It tends to have lots of whole foods and not a lot of ultra-processed foods. But one way or another, through diet or through nutrition, for optimal nutritional status, you need to replace your essential vitamins, micronutrients, and macros. And then exercise, again, movement pastime to last a lifetime. Optimal is some resistance training, which you do a great job of, and then some both vigorous, at least one day a week, cardio, and also zone 2 cardio. Ideally at least 90 minutes, but anybody listening to this is probably going to get way more than that. So that's great. And then past that, I mentioned sleep. Sleep is probably the third most important one for a multitude of reasons, but that's quality and quantity of sleep. So as I mentioned, with social health, that is you and your family unit or your household going through life together. Whatever you do, for the better or for the worse of your health, you're more likely to have success if you go through it as a family or a tribal unit, whatever you want to look at it as. Stress is next, and just like lifting a weight, you want to make lifting the weight feel good. You want to make the stress in your life feel good as well. Again, that has to testosterone does help effort feel good, so that's one of the things that you want to consider. But you also want to use progressive overload to where you're not mega loading stress in your life. You learn to adapt to it. And then past that, you have sunlight. That's just exposure to the elements. Humans have not lived indoors in an artificial environment near as much as we do now. So that includes cold, heat, which sauna, cold exposure in the morning. The last pillar is the spiritual pillar, and that's just on Maslow's hierarchy of needs. There's a pyramid, and your metaphysical need, or basically your purpose in life, that's what spiritual means. It does not have to be a religious goal, and everybody has a spiritual need outside of that. It could just be meditation or mindfulness. For me, it's prayer. I'm a Christian. But at the end of the day, you have to think about why you are put here, or maybe the reason why you're put here is nothing. Finding identity in being a nihilist is also technically meeting your spiritual pillar of health. But it's an important thing to see, and medical doctors see this very commonly in end-of-life care. Let's say I was diagnosed with glioblastoma, which is a very severe brain cancer in general. And within the week, I'd probably be talking a lot about my spirituality, and maybe I should talk about it more, even if I don't have a terminal cancer diagnosis. But it's very common to see individuals who are, aware of their mortality to concentrate a lot on their spiritual health.
Interesting. That makes perfect sense. Especially that last one about mortality. I feel like that's something we definitely don't think about on a daily basis. It's something we don't think about enough. But it's like when I just had a friend a few months ago. He had a heart attack doing sprints on the track, and he's my age. He's like 25, and everything he posts now, everything he talks about is all about like, dude, our life is so short. Like we only have this limited time on earth, and it was that perspective shift because he essentially met mortality in some regard. And I think that's something a lot of us are probably missing.
Yeah, it's interesting how the question of how we got here is not easily answered. And most people can go their whole life being agnostic. For me, being agnostic would be extremely hard. It's harder for me to just not know than to believe in something like a natural intelligence. A lot of people believe in an artificial intelligence. I think it's easier to believe in a natural intelligence. But it is very common to see agnostics or atheists or whatnot at end-of-life care or palliative care. Very commonly, they want to talk to a chaplain in the hospital because they just want to hear them out. And I would just encourage people and their family unit to not wait until a terminal diagnosis to do so, because I guess you could argue that would skew your, for better or for worse, that would skew your priorities as well. So it's good to think about holistically, just as you think about your mental health and you think about your physical health. I don't think spiritual health should be stigmatized.
I love this whole lifestyle-based practice that you have in this holistic approach to health. Is this something that you were taught in school, or something that you've developed through your own experiences and like working with patients, or where did this approach come from?
I think it's something that I have developed to some degree along the way. My dad, as I mentioned, is also a full spectrum family physician. In the Midwest, again, a lot of us kind of do it all, anything from delivering babies and newborn care all the way to palliative care at the end of the life. And I know that, so it's a faith-based practice. I used to practice at his practice. Now I have my own Gillett Health, and they got bought out by the hospital system. Long story, but a lot of previously small independent practices are in the same place. But it is a faith-based practice. It does not force faith on anyone, but it's very common for my dad and his partners to pray for their patients. And that's something that I've definitely picked up and continued to incorporate, even as I'm no longer at that practice.
I love that. I had a friend a couple weeks ago. They went to, I think it was a therapist or some sort of doctor, and they were having some anxiety and some like dizziness and stuff like that. And the first thing that the doctor recommended was, here's some prescriptions, instead of, oh, how much are you sleeping? And what does your diet look like? How much are you exercising? Didn't ask any of those questions, just straight to the prescriptions. What's your take on that?
Yeah, that's tough. The way I see prescriptions and the way I see supplements is they are tools to help the lifestyle intervention work. So if you're stuck in quicksand, I'm not against people using a shovel or even a backhoe to get out. but they should learn at least how to somewhat dig themselves out rather than somebody else solely doing it. Because once you get to the top, you need to get out of that quicksand and then move away. Otherwise, you remove the tool and you just sink straight back into the quicksand. It's okay to want to feel better, but taking a medication that might alter your serotonergic or dopaminergic input is not necessarily going to cure what's going on. In a lot of cases of mood disorder, if you do nothing at all, it tends to get better in 6 to 9 months. And there's a lot of potential downsides of using medication if someone's not familiar with the side effects. That's the way I see supplements and medications. They're just substances that have an effect on the body. That's called pharmacodynamics. And the body has an effect on them. That's called pharmacokinetics. That's highly individualized, depending on your genetics and depending on the health of your liver and your kidneys. But they are tools to help. I'm not against them, but I'm obviously a lifestyle first practitioner.
Yeah, I love that. I wish that was more widespread, because I feel like, unfortunately, there's not a lot of doctors or medical practitioners that take that lifestyle approach, whether it's because of money influences or their schooling background, whatever it is. But it seems like it's kind of few and far between to hear somebody with more of a holistic lifestyle approach like yourself. Are you more? Do you think you're more of an outlier in that regard?
It's hard to say, because if you look at the algorithm, it's tough. There's studies, and if the average general practitioner takes 5 minutes and counsels all their patients about diet and exercise, it makes no difference in what the patient will actually do. Now, whether that's a chicken or the egg, maybe the patient doesn't trust the diet and lifestyle advice from their provider because they think he or she is a hypocrite, or they think he or she is bought off by big pharma, or whatever the reason is. But that is kind of like a known fact in the clinical literature. And it's also known that if you take this versus placebo, what would work and not work. So that's the good thing about medications, is they're very well studied, both from an efficacy standpoint, how well they work, and a side effect standpoint. Those things aren't always conveyed, but that is a positive of them. Conversely, in medical education, they're actually, and I would say this is for all doctors across the board. I only intricately know how the training is at the University of Kansas, where I went to med school. But two of the most popular interest groups are food as medicine and exercise as medicine. And I think those are probably the two most popular groups, and they're relatively new. And there's a lot of physicians all over the country that are involved in them. But then as they finish med school and go through a very grueling residency and get out into practice, where they're incentivized to have 5-minute visits, and basically you're just following an algorithm like a robot could, or like a chat GPT could. You are quantified by different criteria, like how many statins you prescribe for diabetics. And that's how you get compensated, rather than what you're counseling the patients to do.
Interesting. Do you think there's a solution to solve that problem?
I think the solution will kind of work its way out. And eventually, I think we'll have single-payer healthcare, where we'll get rid of insurance companies, which I think will be good for everyone, even if some people don't think so. And then outside of the kind of Medicare for everyone system, we'll be able to provide quality care where people can seek out healthcare providers. There's already a lot of direct primary cares, of which Gillette Health is a direct primary care. It's one of our offerings outside of our individualized and functional medicine. But I think that those will become extremely common when we finally have single payer.
Yeah. Do you think that we're kind of go down a rabbit hole of this, I guess, but do you think that that could happen like within our lifetime of moving towards a single payer? Or do you think that's like just so far down the road that we won't ever see that in our lifetime?
I think there's a 100% chance that we will have single payer, or at least mostly single payer, in our lifetime.
Interesting. Okay. Well, I hope to see that soon, because it sounds like, the whole industry, I'm not a part of it, but just from the outside, it seems like kind of a mess. So I'm sure you being on the inside, you can see everything else even more, I'm sure. But going back to hormone optimization, so the 6 pillars of health, if you had to describe an ideal day or an ideal week for somebody to incorporate all of those pillars, how would you prescribe an ideal day or an ideal week for somebody?
Yeah. It's easy to use myself as an example. I have two young kids, 2 years old and 3 years old. I'm married. So there's definitely a lot of things outside of work that I suppose I'm responsible for, or that I feel enjoyment to do. I'm glad to be a part of the process of raising those kids and being part of the family. So that can definitely make, like your biohacking routine very difficult. I don't spend $2 million per year on myself trying to be as young as possible, but I also try to age as, be a good steward of the body that I've been given. I might have, as I mentioned earlier on in the video, I might have not been dealt an optimal perfect deck of cards, but nobody really has been. So figuring out what is your biggest crack in the foundation, if you will, and then finding out how to patch that or at least prevent that from progressing is how you would find your unique area to target. Outside of that, in general, waking up and going to bed at roughly the same time of the day. Again, I've probably delivered 250 babies. Back when I was doing that, I recently stopped. That was very difficult to do. When I was doing shift work or 24-hour shifts, very difficult to do. But now I have a routine where I go to the gym every morning. Even though it's not optimal training sessions, that's when I can get it in. Yes, it would be better if I was caffeinated and not as dehydrated when I exercise, and if I had a better pre-workout meal, and if I did it in the later morning instead of right when I get up. But that's just when I can get it done. So again, just kind of like the optimal diet is one you could adhere to. That's my optimal training regimen. I try to eat a huge meal after I exercise in the morning. So, nutrient partitioning isn't extremely important. But again, that's when I can get in good calories. I'm starving. I eat a lot of whole foods. I eat plenty of protein. And that's something that I can adhere to over a long-term basis. And then with sleep, I kind of already mentioned going to bed at the same time. I try to not consume caffeine. I use a 10-3-2-1 rule. No caffeine within 10 hours of going to sleep. No vigorous exercise or huge meals within 3 and 2 hours, and no bright blue or bright white light within 1 hour. And then I try to incorporate some degree of social health in there as well. Everybody is slightly more or less social. I know Myers-Briggs uses like a extroverted versus introverted term, and I tend to enjoy being around people. Unfortunately, I can do that at work. And then coming home, I try to not bring anything home from work that would otherwise affect the social health of the family.
That's amazing. Do you try and incorporate, I know you kind of mentioned earlier, like cold exposure, heat exposure, like cold plunge sauna. Do you incorporate that into your own routine?
I end my morning shower on cold, but other than that, I actually don't. Very seldom I will sauna. Eventually I would like to do both, but it's not something that I have as a part of my routine at this time.
For people out there, I would imagine you would recommend getting blood work done at some point if they haven't before. Is there like a certain frequency at which they should get blood work done, or do you think people need to get blood work done at all? What's your kind of recommendation on that?
Yeah. Just like there's kind of three types of people with cars, there's three types of humans with their health. There's the car owners that baby their car. They give it a paint job every year. Maybe it's a garage queen. They're constantly running diagnostics. They take it to the fancy mechanic, or they have a pit crew chief. They race their car or whatever it is. They have turbochargers. And those individuals are constantly reassessing their car. That might be like the individual that does labs every 3 months. And I'm not a car guy, but I'm personally that way with my body. Unless technology changes, we only have one body. And at the end of the day, we are organic machines. So I want to have a high performance antique car someday. So that's what I do. And that's what car owners that want to have a high performance antique car do. Then there's people who just get their oil changed and tires rotated. That's like a once a year lab type of a person, and that is fine. And then there's car owners that just never get any labs done whatsoever until they drive the car until the wheels fall off, leave it on the side of the road, and then buy a new one. And I respect that if you do that with your car, but probably not the best idea with your body.
Is there, say somebody feels good, whatever that relatively means to them, and they don't see any issues with their health, like, is there a reason to go get blood work done? That was kind of my thing, and that's why I'm 26 now. I just got blood work done for the first time a couple of months ago because I always felt like I was pretty good, pretty healthy. Would you encourage somebody like that to go get blood work regardless of how they feel?
Absolutely. At least one time. It's a good baseline. And odds are, if you get a complete enough panel, and if people are interested, I posted the panels that I've designed on my website, gilletthealth.com. It is very reasonable to get that as a, I guess, precursor. That way in the future, if something changes, have I had that for years? Is it brand new? But if someone feels good, then they certainly don't have to get labs twice a year just to get labs if everything's perfect. I'd say 90+% of individuals who would get labs, you would find at least one thing that you can slightly alter to improve your health.
I love that. That makes perfect sense. I want to ask you about some strength training stuff. Kind of similar questions around strength training as I asked you for running. Like, can you strength train too much? Is there like an optimal time per week that you should spend strength training? Is it better to, well, I guess we can start with there and then we'll kind of dive into some other questions.
Yeah, you can definitely strength train too much, but it is difficult to train so much to where if it's true strength training, if it's anaerobic, most people do not train hard enough to get there. Now, if we have any like bodybuilders or power lifters or whatnot, or Olympic lifters listening, then yes, there's plenty of those individuals that are overtrained, but the average person is not going to be overtrained. If they're sore, it's just because they're not well acclimated to it, and they need to dip their foot in a little bit slower. So strength training, usually not as concerning, especially for runners. They're just not accustomed to it. And if you do a leg day, then it's going to take a while to have less muscle soreness with your leg days. But yeah, as far as the frequency, 2 to 3 times a week doing a mostly full body workout is good enough for health reasons, not for performance reasons if you're trying to lift a lot of weight. But for a lot of runners, that would be a good frequency to implement.
Awesome. It's 2 to 3 times a week. That's like, I feel like for most people, that's very doable, I would imagine. Is there any correlation between like lifting heavy with like lower reps as opposed to high reps, low weight, or just doing body weight? Is there any correlation between those and the effects on hormones?
Not a lot. Again, there's quite a bit of connection between localized hormone release. If you have a medium weight lift with lots of muscle groups, if you check serum levels of hormones around the time of exercise, then they'll transiently increase and then very quickly decrease. But that's because you're using more major muscle groups. So there are some workouts that are certainly, and I guess part of a good reason or a good example of this would be, are leg days anabolic, or are you going to boost your testosterone by just doing a leg day? And the answer that you can take away from that is no. But the other answer you can take away from it is you are going to locally help your posterior chain, your anterior chain, your leg, assuming that you're doing, like, let's say you're doing squats. You're going to help your core stabilization muscles. You're going to help your quads, your hamstrings, your glutes, assuming you're like locking out and lifting correctly. In a way similar to how having slightly higher testosterone and slightly higher growth hormone would be, because you get the autocrine and paracrine effects of those hormones. And then you also just get localized growth factors and leakier capillaries in general, and more muscle growth and more tendon and ligament reorganization. And then it also, cross-training in general, of course, corrects lots of imbalances. So if you're accustomed to using your, let's say, hamstrings and calves a lot, then some training that helps your anterior part of your leg will help balance things out.
That makes sense. And would you say the same goes for you if you don't have access to a gym or weights and if you just did everything body weight? I would imagine it'd be to a lower extent, or can you still get those same benefits?
You can get the benefits, but you do require a lot of time under tension.
Okay, so maybe just incorporating more tempo, essentially, or just more reps, I guess.
Yeah, with body weight, if you're very well trained and you have a relatively low body weight, then you might need quite a few reps to get a similar benefit.
Okay, that makes sense. I did also want to ask you about intermittent fasting or training in a fasted state. Do you know if that has any effects on hormone optimization?
Yeah, intermittent fasting has a lot of health benefits as far as improving your testosterone or improving your growth hormone. It does increase the amount of growth hormone secretion you have the next night. But again, if you're looking at the area under the curve of growth hormone, it's not going to have a lot of downstream effects to, for example, you're not going to increase your IGF-1 as much. In general, you can think of your IGF-1 as your growth hormone plus your insulin equals your IGF-1. And yes, there's free IGF-1 and there's IGF binding peptides and there's IGF-1 receptors, and growth hormone has effects outside of IGF-1. But intermittent fasting is not necessarily a way to boost your growth hormone, and generally might not want to boost your growth hormone. But it does have a lot of health benefits because it is one way, again, that you can get a diet that you could adhere to that keeps you at either a caloric deficit or maintenance or sometimes surplus that you can adhere to. Well, intermittent fasting is usually not that great for a caloric surplus, but for the average American, keeping you at maintenance or in a little bit of a deficit until you get to a body weight set point. IF or time restricted feeding is kind of like the sequela to that, is one good way to do it that a lot of people enjoy doing. For myself personally, I have a very difficult time doing that. And yes, I know you can get used to it over a long period of time, but it's just not convenient for my social and family and habit lifestyle. And it would be difficult for me to adhere to.
You kind of mentioned growth hormone in there. What would be an instance of somebody that would want to increase their growth hormones? I'm assuming if they're trying to put on like lean muscle mass.
Yeah, I suppose if someone is growth hormone deficient, then sleeping more is a great way to do that, or not eating within an hour or so of going to sleep. Growth hormone, especially for males, is not particularly important for putting on muscle mass. But if you're growth hormone deficient, you will certainly build up more visceral adipose tissue. Tissue in and around the peritoneum, for example, the liver, the spleen, basically inside the abdomen. And that has a lot of health detriments. So if you're borderline growth hormone deficient, you can check that. You can look and see what your standard deviation is for your age. And you usually do that by checking an IGF-1, which is downstream to growth hormone. In general, if it is below 100, or if you're over the age of about 65, below 80, then you should certainly consider strategies, whether they're medications or whether they are lifestyle interventions to improve your growth hormone.
Is that an important metric for like runners to pay attention to?
Probably not, unless they're having a significant amount of trouble sleeping. Also, if they happen to be type 1 diabetic, then they likely have very high growth hormone levels, but low IGF-1. Okay.
Interesting. Man, this was super, super informative. I appreciate you coming on and sharing all this knowledge with us. Where is the best place for people to find you, connect with you, or reach out to your practice?
Yeah, my main hub is Instagram, Kyle Gillett MD, and I'm on all other platforms, Gillett Health, and I have a relatively new YouTube channel and podcast called Gillett Health on all platforms.
Amazing. Thanks again for coming on, man. Super, super informational, very informative. I think people are going to take a lot out of this. So thanks again for coming on and sharing your wisdom with us.
Thank you. My pleasure.
Thank you so much for tuning into the show. If you enjoyed this episode, please make sure to subscribe to the channel, leave a review, and share it with a friend. We'll see you in the next one.